On behalf of Abbott, I'd like to welcome everyone to the Abbott Molecular Dinner Speaking Program here in San Francisco. We have a distinguished speaker today, Dr. Ashish Kamat from the MD Anderson Cancer Center. Dr. Kamat is a tenured professor of urology and the director of Urologic Oncology Fellowship at MD Anderson Cancer Center and a graduate of the AUA Leadership Program. Dr. Kamat's expertise is in multidisciplinary management of urologic cancers with an emphasis on bladder and prostate cancer, organ-sparing therapies, minimally invasive techniques, and orthotopic bladder substitution. While he is a busy surgeon, he maintains an active research portfolio to improve the care of patients. Dr. Kamat's efforts are directed towards identifying predictors of response to therapy, especially immunotherapy, as a first step towards personalized cancer therapeutics. A major focus of his laboratory research is to develop novel treatments for bladder cancer and identify resistance mechanisms and ways to overcome them. He serves as a project PI on the MD Anderson Cancer Center GU Bladder Spore. Dr. Kamat has authored over 200 publications, editorials, and book chapters in prestigious journals. He is listed in Who's Who in Medicine and Best Doctors in America and has won the Compassionate Doctor Award from patient groups. He is an exceptional educator nominated twice for the Robert M. Chamberlain Distinguished Mentor Award and has been invited as a visiting professor to several universities across the world. Dr. Kamat is co-president of the International Bladder Cancer Network, chair of the Bladder Cancer Think Tank in 2015, and chair of the Bladder Cancer Task Force for SITC, and actively participates in various global urologic efforts and serves on the board of regional and national societies of urology. Please welcome Dr. Kamat.
Thank you very much. So thank you for that kind introduction. What I'm going to cover today essentially is predicting response to intravesical immunotherapy. And it's mainly BCG, but really we look forward to being able to predict response to any intravesical therapy because immunotherapy for bladder cancer, as you know, is really in an exploding field right now. Here are some disclosure slides. This is the Eurovision slide with the intended use and limitations on here. I wanted to start out a little bit since diagnostics and looking at cytology really involves visual cues. So take a look at this slide and tell me, or don't tell me yet, but keep to yourself, how many legs do you think this elephant has? Okay, and I'll show this slide later, but just try to tell yourself how many legs you think this elephant has. And then some of you may have seen this slide before. It sort of really emphasizes a visual issue that we all face when we're looking at colors and perception. But look at square A and square B. And again, keep this to yourself because I'll bring this up again later. Which square do you think is actually darker between A and B? Okay? So just a little two visual questions for you, and then let me kind of start out with a little case example. So cases are always important because they help us understand how what we're talking about actually affects patients in the real world. So this is a 52-year-old male, usual presenting symptoms of microhematuria, otherwise healthy, was a smoker, was evaluated with the usual imaging, the CT urogram and a cystoscopy, was found to have about a 1.5 centimeter high-grade tumor on the left lateral wall. This was appropriately resected, found to be T1 high grade, then resected again, and there was no residual disease. This patient was started intravesical BCG therapy, which is the standard of care for these kind of patients, and underwent maintenance at 3 months after negative cystoscopy. The patient then had a 6-month surveillance cystoscopy, which was negative. Cytology at that point was negative, but the FISH was positive. Because the cystoscopy was clear, the urologist decided to just continue with the BCG. The patient had a 9-month evaluation with cystoscopy. Cytology at this point was negative, as it was at the 6-month. At the 12-month, the cytology was atypical. The urologist obtained a Eurovision test. It was positive. The patient underwent evaluation. Cystoscopy again was negative, and the urologist appropriately looked in the bladder, looked in the uterus, did the appropriate imaging, and because they couldn't find anything, said, well, the positive FISH is because there's a lot of inflammation in the bladder from BCG, and stopped the BCG for this patient because they were concerned that the BCG was inducing abnormal test results. The patient went on having surveillance cystoscopies, essentially was rendered or on paper was put down as no evidence of disease. Cytology wasn't done either because the cytologies were negative in the past and FISH was positive, so the urologist felt, well, there's no point doing any more marker studies. And we sort of know now that cytology doesn't perform well, so it's understandable that someone wouldn't want to get cytology. But when this patient went on at 24 months, the 2-year mark, had actually gross hematuria again, so frank bleeding in the urine. Cytology at this point was positive, and the Eurovision FISH was, again, also positive. And the urologist decided, well, rather than look in the bladder and do all the workup again, let me send the patient to me at this point for blue light cystoscopy, enhanced cystoscopy, which the urologist didn't have in his or her office. So, of course, I saw the patient, reviewed the pathology, had a conversation with the patient, repeated imaging, which was negative at this point. And the plan was to take the patient to the operating room to look in the bladder, do blue light evaluation, do biopsies of the bladder, prostate, etc. But as soon as you look into the urethra, I don't know if you can see this on the slide or on the screen, but there's clearly tumor in the prostatic urethra. And we resected this tumor in the prostatic urethra, and it ended up being high-grade bladder cancer, not only involving the mucosa of the prostatic urethra, but actually invading into the stroma of the prostate, T4 disease, which is bad. So the patient underwent chemotherapy, needed a radical cystectomy, underwent a radical cystectomy. The pathology was T1 in the bladder after chemo, so this is not, someone that's responded dramatically to chemotherapy, but it did get downstage. However, when this patient's nodes were evaluated, there were 47 lymph nodes removed, but 6 lymph nodes were positive, and that's really bad disease per se. We counseled the patient on adjuvant chemotherapy because at that point there was no immunotherapy as far as the systemic immunotherapy agents available. Patient decided to observe and not go on any actual treatment. You can see the CT scan 6 months later, widespread metastatic disease all over the liver, and this young patient unfortunately succumbed to his disease. So it's a real good reminder as to how we need to pay attention to active surveillance in these patients. Pay attention to the markers that we're obtaining and actually listen to what the marker is trying to tell us, and not ignore it and not pay attention to what it's saying. So I talked about BCG, and that's what this patient got, and I'll talk about BCG as far as the predicting the response is concerned, because it is really the most common treatment that we have for bladder cancer patients nowadays. You hear a lot about immunotherapy, you see it in the news, you see it on the Wall Street Journal, because it is come back into vogue, so to speak, for bladder cancer. But really, if you think about it, we've had BCG for more than 4 decades when it comes to management of patients with bladder cancer. It is the original cancer immunotherapy. Globally, there's about 1.2 million doses of BCG administered to bladder cancer patients every year. But as of today, we still do not know how to predict which patients are going to respond to BCG and which patients are not going to respond. And as you saw from the case example, if a patient doesn't respond to BCG and enough time elapses, this patient actually gets really aggressive invasive disease that can metastasize and take the life of our patient. So before I go into predicting response to BCG, I want to touch upon a few myths when it comes to BCG therapy. And the reason these myths exist is because we've had BCG for 40 years. There have been multiple markers looked at to try and predict who's going to respond, not respond. But as you can imagine, when there's 40 years of data that's been out there, people forget the basics. So this is sort of like going over some of the basics of intravesical BCG when it comes to bladder cancer. So the biggest myth that you often hear from urologists is that BCG doesn't actually reduce progression of disease. It only reduces recurrence rates. This is just not true. And this is an old slide. It's from Richard Sylvester, who runs most of the trials for the ERTC, is their lead biostatistician. And it's a busy slide, but you can see the green line is to the left of the screen as you're looking at it. That pretty much means that these trials showed a benefit of BCG when it came to reducing progression of disease when maintenance BCG was used. And that's another point that I want to make, is that BCG does reduce progression rates, not just reduces recurrence rates, but it reduces progression only when maintenance therapy is used. Again, this is the graph that shows that. The fact that you can see the blocks to the left of the midline there suggests that BCG reduces progression, but only when maintenance therapy is used. The second myth is that, okay, fine, I'm going to use maintenance BCG, but I don't know what the maintenance schedule is, or that there's no real optimal maintenance schedule that has been identified. And again, this is just not true. It's something that's been propagated because people have looked at older studies that don't actually show a benefit with maintenance therapy. This is the classic SWOG protocol that showed that maintenance BCG reduces recurrences and progression from bladder cancer. And the top line is maintenance therapy, and the bottom two are induction alone. But what I mean by that is that induction BCG essentially is 6 weeks of BCG. So patients get BCG once a week for 6 weeks, and that's considered induction BCG. The SWOG protocol, or the Don Lamb protocol, or the standard protocol nowadays for maintenance therapy, is you get the 6 weeks of induction BCG and then get 3 weekly maintenances. So once a week for 3 weeks at month 3, month 6, and every 6 months thereafter for 3 years. And that's the maintenance therapy that actually shows a benefit to maintenance therapy with BCG from reducing recurrences and progression. The reason a lot of people say maintenance therapy doesn't work is because they're referring to trials such as these. This is where one installation of BCG was given every 3 months. It was studied as maintenance therapy, but this maintenance therapy didn't actually help the patients over induction alone. This is another regimen that was studied, and these are large cancer centers that have looked at this, and this is giving one installation of BCG every month. And again, that is maintenance therapy, but this maintenance doesn't actually work. It has to be done once a week for 3 weeks as the SWOG protocol. And the most common mistake that we as urologists used to make is give a patient 6 weeks of BCG and then just wait 6 months, give another 6 weeks of BCG, and call that maintenance therapy. But again, as you can see here from a study that was done in Spain by Jean Paulot, that maintenance BCG doesn't actually work any better than induction alone. So when patients are told by the urologist that maintenance therapy doesn't work, they're not wrong. The wrong type of maintenance doesn't work, but if you do the maintenance right, clearly maintenance therapy works. And there's actually scientific evidence to back this up. This is a study that was done in 1999 looking at cytokines in the urine. It looked and to see why the patients developed the immune response. You can see here at the induction BCG, when someone is immunotherapy naive, you get a rise in the cytokines from week 1, 2, 3, 4, 5, all the way up to 6. But when the patients already received BCG, if they get 1, 2, and 3 installations of BCG, their immune system's getting ramped up. But if you give them too much BCG, it's an immunotherapy, you're actually suppressing the immune system. So that's where the 3 weeks of maintenance therapy comes in. And it's also important when it comes to looking at patients today that are being deemed to be BCG failures. You know, patients with carcinoma in situ are looked at in the bladder at 3 months, and someone calls them a failure. They go on clinical trials, and the clinical trial shows some benefit, 10, 15, 20%, and that drug that's being studied is looked at as a success. But if you look at the actual timing of recurrence of patients with carcinoma in situ with BCG, this is again adopted from Don Lamb's study back in 2000. These are patients with carcinoma in situ that were randomized into 2 arms, one that got maintenance BCG, one that got induction BCG alone. And as expected, after an initial induction course of BCG, at the 3-month mark, the CR rates, complete response rates, are about 55–58%. Now, in the arm that went on observation, so no more maintenance BCG, the CR went up just with time, because immunotherapy requires some time to work. It went from 58% to 69%. But look what happens when you give these patients maintenance BCG. The CR goes from 55% to 84%. So imagine if patients, and this happens even today, patients at the 3-month mark without getting maintenance BCG are told, well, you've had induction BCG, you failed therapy, let's try an experimental drug. That drug is put in, and we know, some drugs have been approved with a 10% response rate. You go from 55 to 65% with that drug, and it's considered a response, but just giving more BCG would take that patient from 55% all the way up to 84%. So it's important to recognize the importance of doing adequate maintenance immunotherapy. And 64% of these so-called failures would have been salvaged if they just had appropriate BCG therapy per se. Another myth is that BCG only works for high-risk disease. It doesn't work for low-grade patients. That is just not true, and people should know this. It's the EORTC 30911 study that clearly showed that even patients that have low-grade disease, and this is a population where cytology just doesn't work, and when you're trying to monitor these patients, cytology is very ineffective. And that's why some urologists don't like to surveil these patients with cytology, which is understandable. But BCG in this population works. So it's a low-grade disease, but it's intermediate risk category because these patients are recurring. And this is actually one population in this study where BCG was shown to reduce deaths. So there's a misconception that low-grade bladder cancer is not going to kill anybody. Again, not true. It can kill our patients. And if you use BCG, you can actually reduce the deaths from bladder cancer in these patients per se. Now, I talked a little bit about risk stratification. I know it gets a little confusing, so I just wanted to put up the slide here. A low-risk bladder cancer is any patient that has a single, first-time, low-grade Ta tumor. A high-risk patient is anybody that has T1 disease or a high-grade cancer. So that's clearly easy to understand. The intermediate risk category that I talked about earlier is patients that don't fall into the low risk or the high risk category. So essentially anybody that has a TA low-grade tumor that's been recurrent, multiple, or large is an intermediate risk patient. And that's the simplified definition that the International Bladder Cancer Group that I lead has put forward and has been adopted. Now, if you're looking at risk stratification within the intermediate risk category of patients, there are ways to do that. We've proposed several risk factors: the number of tumors, the size of the tumors, how often the tumor occurs, and the frequent recurrences. And again, this is available to help risk stratify which patients should go on to get treated, such as low-risk patients, which patients should get treated such as the high risk, and which patients fall into the true intermediate risk category. The last sort of myth that I want to touch upon a little bit again is that not all patients can tolerate a full course of BCG. And this is really important because urologists will often just stop BCG at an arbitrary time point, claiming that the patient can't finish the course of BCG. This was true back in the 1990s when the studies were started, because we weren't smart enough to actually recognize little things that we can do to help our patients, using aspirin, for example, or using antispasmodics, or just stretching out the interval of their BCG therapy. So back when the trials were done, the SWOG protocol, for example, only 16% of patients actually finished a full 3-year course of BCG. Today, however, when you look at multiple trials that have been performed, the EORTC 30962, for example, the IPD survey that the International Bladder Cancer Group performed, you can see that less than 10% of patients, 5% in the IPD study, had to stop BCG. So going from where 84% of patients had to stop the BCG before they reached 3 years to less than 10% having to stop BCG is clearly because urologists have gotten smarter. They know how to manage side effects. There are more drugs available for us to use, and patients have gotten a little bit more smart as well, so they are motivated to go on to get the full course of BCG and do everything they can in order to improve their results with the immunotherapy. Now, the fifth myth really is what the main subject of this talk is how do we predict response to BCG? So it's sort of a tongue-in-cheek myth, the fact that we can't predict response to BCG. We can, but we don't really have very robust tools unless you know exactly what to use. So when it comes to predicting response to BCG, what do we have today in 2018? Well, we have the standard clinical pathologic features: the patient's gender, the grade, the stage of tumor, the presence or absence of CIS, how deep the tumor is in the lamina propria, whether there's a variant histology, the RE2UR data, prior intravesical therapy, and the FISH status, the Eurovision FISH pattern of these patients per se. So let me touch upon these a little briefly. So again, the Spanish group put together a QETA score. This is a Spanish organization. The Europeans have done the same as well. We don't have that with the AUA in the US, but there are groups putting together these sort of nomograms. You can clearly see that you can give these patients different scores based on their gender, the number of tumors, the grade, stage. This is just common things that we as urologists use, and you can predict who is going to respond as far as recurrence patterns are concerned, and who's going to respond as far as progression is concerned. This is something that's not new. It's just been quantified by these several studies. Re-TUR data is something that's very important. So we have patients that have a tumor that's been resected, and then we take them back to the OR and do another resection to make sure we cleared out all the tumor from the bladder. As you can see here, when it comes to predicting response to intravesical therapy, patients who have had T1 high-grade disease on the initial resection and then again have T1 high-grade disease on the repeat resection have only a 19% response to the intravesical therapy. If they don't have T1 high-grade, the response rate is 82%. So the re-TUR data does help us know who's going to respond, who's not going to respond to BCG therapy. The presence of variant histology. This, for example, is micropapillary bladder cancer. This is a cohort of patients that were referred to us that had micropapillary bladder cancer, T1 high grade, got BCG. And you can clearly see here that the large majority, 89%, recurred, but more impressively, 67% of these patients progressed, and they progressed rapidly. So they went from non-invasive disease to invasive metastatic disease, all at a median time point of 8 months, simply by virtue of having variant histology. So nowadays we know that variant histology predicts for a poor response to BCG therapy. Now, looking at different tumor biomarkers has obviously been in vogue for many years. People have looked at P53 when it comes to bladder tumors. They've looked at correlating this with response, and there have been studies that show that P53 status does correlate with response to BCG, but there have been just as many studies suggesting that it doesn't correlate with response to BCG. The same problem with any of the other markers that you look at when you're looking at tumor cells. And the reason for this really is that BCG is an immune therapy, right? So it works by stimulating the host immune response and hence manifests the anti-tumor activity. So if you're only looking at tumor characteristics, it's not going to show you the entire picture when it comes to BCG response. And that's why people have looked at antibody response to BCG. This is a study that was actually performed many years ago in 1981, where they looked at the antibody response of the patients to BCG therapy and showed that clearly if a patient has appropriate antibodies in the blood, they have a better response to BCG when it comes to their bladder cancer. And again, using this data, people have looked at cytokines, they've looked at IL-2, IL-8, individual cytokines, and shown sort of a separation. You can see these curves separate a little bit, but you're really not going to tell your patient to have a radical cystectomy based on a slight separation of their curves, because this really clinically isn't that relevant. So we put forward a trial trying to look at prospective markers of response to BCG therapy. This is a trial that was registered with the NCI. It was supported by the SPORE program at MD Anderson, and the hypothesis really was twofold. Number one, can we look at cytokines, which help us look at the immune response of these patients to BCG, and can we look at the FISH patterns in order to look at the cytogenically abnormal cells that these patients have in their bladder. And the hypothesis was that the cytokines will help us predict the response, and the FISH patterns will also help us predict response. So I'll bottom line this, the cytokine response did allow us to predict response to patients and differentiate responders from non-responders. The responders essentially have higher levels of cytokine response to BCG in the bladder. The magnitude of induction of the cytokines is higher in patients that have got response to BCG, but it's a complex interplay of the cytokines in the bladder. And that's why the previous studies really didn't show a large separation. I just want to show one example. This is IL-8 induction in the urine of patients. You can see here that you get a p-value that is statistically significant. It's p less than 0.0041, but there is a fair amount of overlap in these boxes. And there's clearly patients who have a recurrence but still have a high cytokine level. And that's because, again, the immune system is fairly complex. So when you look at this, it's not a clear linear correlation. The higher the amount of BCG-induced IL-8, the better it is up to a certain point. But beyond that, you're actually overwhelming the immune system and you're suppressing the response to intravesical immunotherapy. So because of that, it's a very complex kind of nomogram that is required to look at the different cytokines in these patients. And we have published this before. It's looking at IL-2, 6, 8, 18, 1RA, TRAIL, gamma, and TNF-alpha. And you can put this in a point system, but it does allow us with a fair amount of accuracy to predict the response of these patients to intravesical therapy. And we call it the CYPRID assay, the cytokine predictors of response to intravesical therapy. It's currently being validated in a large multi-center study here in the US and also overseas. And the area under the curve is 0.85, so it's about 85% accurate, which is almost too good to be true. So it definitely needs to be validated. Now, coming to the FISH patterns of these patients, again, this was the hypothesis of the trial, that the FISH patterns will help us predict the response to intravesical BCG. You all know that the Eurovision FISH was F1 510K cleared in 2001 and then approved in 2005 for diagnosis in symptomatic patients with hematuria. It's based on molecular probes that detect certain genetic alterations in the urine cells that are shed, and it looks at the 4 probes on chromosome 3, 7, 17 and the 9p deletion. And this is just a graphical representation of what it looks like under the microscope. You guys know this a lot better than I do. And the scoring, I put this slide up here mainly to emphasize one point. Oftentimes you'll get reports that say, well, 500 cells were looked at in an automated fashion and 4 were picked up, or we looked at 2 cells and didn't pick up anything, and we call it negative. So it's important for people to recognize that you have to select the morphologically abnormal cells, and these could be from size of these cells, if the cells are irregular, if they have abnormal DAPI staining. They shouldn't be overlapping because you have to be able to identify these clusters. And if there are no abnormal cells visible, then of course you want to scan all the cells. But if you have these abnormal cells, a minimum analysis of 25 cells needs to be performed, and then the patient is deemed to be FISH positive as approved by the FDA if 4 or more cells have a gain of at least 2 of 3,717, or 12 or more cells have a deletion of 9p21. That's the p16 signal. And this is important because oftentimes we see patients that are referred with FISH test that's been reported out as either positive, negative, but it's not been done the appropriate manner. And that may have significance, and that's been studied by our group and others, but it's not a classic FISH positive or negative. So when we designed this trial, we went with the classic FISH positive or negative based on the approved FDA indication. And this is, again, it in a nutshell. So you can see we did FISH on these patients at baseline. We did FISH on these patients at 6 weeks after resection of the tumor, at 3 months and 6 months. And at every time point, you can see that the FISH positive patients had a worse outcome compared to FISH negative patients. So at baseline, you can see a separation. It's statistically significant. As early as 6 weeks after resection of the tumor, FISH positive patients did worse than FISH negative patients. Same thing at 3 months and same thing at 6 months. And as you go longer and longer out from the initial resection, the curves do separate. And this is important because it allows us to actually adjust not only our risk stratification of these patients when we're looking at them in a clinical scenario, but it also helps us kind of adjust the surveillance pattern of these patients. And I know we do this, and in the community, my colleagues do this as well. If a patient is FISH negative, you feel a little bit more at ease, and the patient's a little bit more at ease at stretching out the interval. If they're positive, FISH positive, obviously we work it up, but if you don't find a tumor in the bladder, you're still got that heightened sense that there's something going on with this patient. We should look in the prostatic urethra, we should look elsewhere in the upper tracts, we should maybe see them more often than just, every 90 days per se. And this data is useful. But again, what I want to emphasize even more is that the pattern of these patients when it comes to FISH positivity. So we get the FISH, for example, at baseline, it's negative. At 6 weeks, it's negative. You can get different combinations of positive, negative. And let me just highlight this. So a patient that's baseline FISH negative, and again, FISH negative at 6 weeks, has a 12-month recurrence percentage of barely 13% and a 0% progression rate all the way up to 2 years. Whereas if a patient is negative at baseline but converts to positive as early as 6 weeks, these patients have almost a 60% recurrence rate at 2 years and 40% progression. So you go from 0% progression all the way up to 40% progression if a patient is negative and converts to positive. And clearly, there's something going on in the bladder of these patients because they were cleared by the TURBT, but despite getting BCG, they're FISH positive, and they have a large potential for not only recurrence, which is bad, but progression, which can kill these patients. So it's clearly something that we use and can use nowadays when it comes to our monitoring these patients. But again, that's important from a clinical perspective. What's even more exciting in a way, and we have used these and other people are starting to use these as well, is to design clinical trials. So if you look at the 3-month data that I showed you earlier, you saw the separation between the FISH positive and negative. This is putting it in numerical terms. If a patient at 3 months after resection of the tumor and starting BCG is FISH positive, they have a 57% recurrence rate at 2 years compared to 8% if they're FISH negative. And they have a 50% progression rate within 2 years compared to 3% if they're FISH negative. So as early as 3 months after resection of tumor, you have this clear separation, 50+% compared to less than 10% of patients. And why is that important? Well, today, when we have a patient that gets on BCG therapy but fails, the standard of care for these patients is to take out their bladder. That's in all the guidelines, that is the standard of care. But clearly, patients don't want to have their bladder taken out when they have non-invasive disease. So what happens? We put them on a clinical trial. But because the comparative arm is a radical cystectomy, we can't really randomize to taking out someone's bladder versus not taking out someone's bladder. So the FDA has agreed, based on our discussions with them, to allow us to do single arm studies. So what that means is a patient who fails BCG goes on a study with a single arm with no control group, and that's actually been allowed to be called a randomized phase 3 study by the FDA. It's just what they do. So patients go on drug, they fail BCG, and they go on a single arm study. But how do you make sense of these studies? There's no control arm. You don't know what you're comparing against. So we, in the International Bladder Cancer Group and the FDA, have proposed certain numbers for people to use. And we've come up with these numbers, and this is based on historical data. If you have CIS, you should have a CR of 50% at 6 months, which should be durable at 12 months to 30% and 25% at 18 months. And if it's papillary disease, again, you don't look at CR as early as 6 months, but then you look at the recurrence-free rate of 30% at 1 year and 25% at 18 months. But again, even though we have these numbers, the point I'm trying to make is it's a single-arm study, right? So you may have a drug that meets these benchmarks, but if you had an appropriate control arm, you wouldn't really be able to see a difference if these patients had less risk factors. And that's where the FISH positivity comes in. So the trial design that we and others have proposed is you have a patient that gets induction BCG, so just 6 weeks of BCG, and if the first evaluation is FISH positive or negative. So if the patient is FISH negative, clearly they have a good outcome. You don't have to worry about a thing. You continue on with the BCG and they're doing well. If they're FISH positive, however, they are at a very high risk of recurrence, 57%, progression, 50%, but they haven't recurred yet. So they don't actually have a tumor that you can see in the bladder, but you know by 2 years they're going to have a high recurrence and progression rate. So these are patients, and you can discuss a clinical trial. You can talk with the patient and say, well, you're at high risk of failure from BCG, so we have a clinical trial that we can provide to you, but the control arm is still BCG. So because here we have the ability to randomize these patients to a novel agent, so BCG plus something, and also ethically continue on BCG because this standard of care, it will allow us to move the field forward if this trial design is adopted by more folks than just a few universities that have looked at this. So this is a trial design that we have proposed and has been adopted by several groups, including GU ASCO in 2013. So I'm going to summarize the talk really. We were asked by the European Association to put forward a nice review of ways in which we can predict response to intravesical therapy today. As you can see, we came up with different tables. The definitely useful before treatment was the clinical parameters that I told you about, the age, grade, stage, etc. of the tumor. And then during and after treatment was the FISH pattern on cytologic examination of the shed cells. This was categorized by the expert panel as being definitely useful. When it came to probably useful, before treatment was biomarkers, genetic profiling of these tumors. It was a separate assay, the cytokine assay that I talked about. And of course, emerging strategies are the molecular subtypes of the tumors, the genetic profiling that you've been hearing about. But today, as of 2018, what do we have available? It's the patient's clinical pathological parameters, age, stage, grade of the tumor, and the FISH pattern. So it's well recognized by experts that using the FISH pattern of these patients does allow us to be able to actually predict who's going to respond to treatment, who's not going to respond to treatment. And that's been recognized by several agencies, including the American Urological Association, that have put in the guidelines, and these are back from 2016, that clearly states that in a patient with non-muscle invasive bladder cancer, a clinician may use biomarkers, and the Eurovision FISH is listed here, to assess the response to intravesical Bcg therapy, and then also to educate equivocal cytology. There's data that's going to be presented at this AUA that will expand on our trial, and I urge you to go and visit and see the presentation, which is going to be tomorrow, actually. There's other data that's coming out from Europe and other larger studies by Mike O'Donnell, for example, that have looked at similar questions and should be published fairly soon. Now, going back to these pictures that I put forward, between A and B, which one do you think is actually darker? Well, they're the same color. It's a visual perception, right? I mean, because you have the green column there, the cones and rods in your eye are not seeing the difference between A and B, and unless you have something connecting it, A looks darker. I mean, it looks darker to 95% of the population. There's 5%, I was hoping none of those 5% would be here, and they're not, that can actually tell the difference with the green cone there. And it's usually the people that are green-red colorblind that can actually say that A and B are the same color. And then this question here, how many legs does this elephant have? 4 or 5? The answer here, I don't know. Thank you.